All right, does anyone have any questions or concerns before we get started? Everything going okay? All right, so I'm just going to finish up Dr. Quadre's lectures tonight. It's pretty dense material, so I thought hopefully we could take our time going through it. To be honest with you guys, I was like, I feel like they don't even need me for his lectures just because he's so good at explaining everything. So I'm reusing a lot of his slides, and I just thought that, you know, re-walking through all of the physiology, especially that's associated with the diuretics, might be helpful. Okay. So just starting very broadly, if you're looking for a place to start, I would start looking at these diuretics based on where they're acting in the nephron. So, sorry guys, my dog's trying to get into the office. Just give me just 1 second. Okay, I'm back. Okay, so anyways, what I was saying is I would start looking real broadly at where these drugs are acting. Because I've noticed a lot of times in practice questions, what will get me is they'll give you like a very complicated question stem and ask you first you have to determine what the best drug is, and then it'll ask you something really simple like where is this drug working, in the proximal tubule, the distal tubule, etc. And that's typically what always gets me. So yeah, a lot of these questions, especially with diuretics, they approach from a physiology standpoint. Okay. And then something that should help is this slide here. So anything working in the collecting duct is going to conserve potassium, and these are known as potassium-sparing diuretics. And then any diuretic working before the collecting duct is going to increase potassium excretion in the urine. So these lead to hypokalemia, where anything working here is going to result in hyperkalemia since it's potassium sparing. Okay. All right, so let's just walk through the physiology here in the proximal convoluted tubule. So over here on the basolateral membrane, you have what's known as your potassium or your sodium potassium ATPase. So I think we're all familiar with this. So for every 3 sodium that's reabsorbed into the body, 2 potassium are going to be excreted back into the cell. Okay, so sorry, just 1 second. Okay, so with acetazolamide, where this drug is working is at carbonic anhydrase. So acetazolamide is known as a carbonic anhydrase inhibitor. And the way this works, so with normal physiology, you have carbon dioxide that's reabsorbed from the tubular lumen, and that's going to combine with water to form carbonic acid. And then the carbonic acid is broken down into bicarb and a proton. The bicarb is going to be reabsorbed into the body through this bicarb chloride exchanger. And then the proton is going to enter the tubular lumen through this sodium hydrogen exchanger. So as a result, if you block carbonic anhydrase, you're preventing the amount of bicarb that's formed in the cell. So you have less bicarb reabsorbed into the body. So as a result, one of the things that you're going to see is metabolic acidosis due to this lack of bicarb reabsorption into the body. And then also important, because you're getting less hydrogen from the breakdown of carbonic acid, you're not getting as much sodium reabsorbed, so less sodium is working through this sodium-potassium ATPase, and that's going to lead to what you see over here, which is hyponatremia. And then because this pump isn't working as well, you're going to see less potassium entering the cell. So you'll still see hypokalemia because, like you said in the lecture, you're reabsorbing sodium throughout like other places in the tubule. So the important thing here is that you're going to see hyponatremia, hypokalemia, and then also metabolic acidosis. Okay. So again with acetazolamide, so one trick to remember one of the important side effects of acetazolamide is that like acid zolamide causes acidosis. And you can use it to treat acute mountain sickness or to restore acid-base balance in heart failure patients. And this is due to the metabolic alkalosis caused by loop diuretics. But then, so the take-home point here is the fact that the use of acetazolamide is going to deplete the body of bicarb, leading to metabolic acidosis. Okay. So now moving on to the thick ascending limb of the loop of Henle. So this is where your loop diuretics are going to work. So let's plug in his animations here real quick. Yep, okay. So over here on the tubular membrane, you have this sodium, potassium, and 2-chloride symporter, and that's going to help the body reabsorb both sodium and chloride. And then at the same time, and of course potassium, and then at the same time you have this sodium-potassium ATPase over here on the basolateral membrane that's working to absorb the sodium, and then potassium enters the cell. So you have potassium entering the cell from the sodium-potassium ATPase, and then you also have potassium entering the cell from the sodium-potassium chloride symporter. So basically that gives you a buildup of potassium here in the cell, and it's going to leave through what they call the Romke channel. So it enters the tubular lumen. So potassium is, of course, positively charged, and then you also have magnesium and calcium sitting here that are also positively charged. So what's going to happen is you have like a repelling effect, and the magnesium and the calcium are going to be reabsorbed into the body paracellularly. So when you block this symporter right here, you have sodium, potassium, and chloride that are staying in the tubular lumen, and then also your recycling of potassium is decreased because your sodium potassium ATPase isn't working as hard. So you have more sodium, potassium, and chloride here since this pump isn't working. So since electropositivity is reduced because you're having less potassium since this pump isn't working as hard, then magnesium and calcium, sodium, and chloride are going to leave through the urine. Okay, so your examples of your loop diuretics would be furosemide, bumetanide, torsemide, and ethacrynic acid. Okay, so one very important use of loop diuretics is the fact that they're going to work to manage hypercalcemia. And again, so the reason that is because you have all of these electrolytes leaving through the tubular lumen. So instead of calcium being reabsorbed paracellularly, because you have a less electropositivity here, because you have less recycling of potassium, instead it's going to leave through the lumen and enter the urine. So one thing that you can use loop diuretics for is to manage hypercalcemia. And then also, an important adverse effect is the fact that NSAIDs can decrease the response to loop diuretics, and that's due to decreased renal blood flow. And if you remember the mechanism for that, so NSAIDs are inhibiting prostaglandin synthesis, which would be acting on the afferent arteriole. Okay. Okay, so now we've reached the distal convoluted tubule. So this picture, don't let it confuse you. He just has it like turned on its side compared to the other ones. So you're looking at the tubular lumen right here, and on that membrane sets this sodium chloride transporter. And this is going to help with sodium and chloride reabsorption into the body through the sodium potassium ATPase again, and then also this chloride channel sitting here. So over here you have calcium, which is being reabsorbed through the tubular lumen under the influence of parathyroid hormone, and it's reabsorbed into the blood through this calcium and sodium exchanger right here. So if you block this sodium and chloride transporter over here, you're going to have a decrease in sodium absorption, and then also sodium reabsorption. And because the concentration of sodium is going to be low inside of the cell because this transporter right here is being blocked, sodium is still going to enter the cell through this sodium and calcium exchanger over here. So this is going to result in an increase in calcium in the blood. And that's due to the influence of parathyroid hormone. Okay, so the most important thing to take away from this slide would be the fact that thiazide diuretics can be used to treat osteoporosis. And this is because one of the adverse effects is hypercalcemia. However, of course, in somebody with osteoporosis, you would actually see that as a benefit. Okay, so made it to the collecting duct. Okay. All right, so we kind of like went over this one, yes, the principal cell the other day when we talked about aldosterone. But just to go through it again, so over here on the tubular lumen, the membrane, you have this sodium channel, which is the ENaC channel. So sodium is going to enter the principal cell through the ENaC channel, and then it's going to be reabsorbed by this sodium potassium ATPase. And then, at the same time, you have, because of that increase in sodium, you have more potassium entering the cell, which is going to be excreted into the tubular lumen via this potassium channel sitting right here. So aldosterone is going to facilitate this by binding to the mineralocorticoid receptor and then increasing gene transcription in 3 different places. So at the sodium potassium ATPase, at the ENaC channel, and at the potassium channel. And, so this effect will be mediated by aldosterone. However, if you use a drug like amiloride or triamterene, you're going to block the ENaC channel, and you're going to reduce sodium reabsorption because you're having less sodium entering the cell. And then as a result, less potassium is going to be excreted into the tubular lumen. So this means that more potassium is conserved in the body, which leads to hyperkalemia. So in the collecting duct, this is where your potassium-sparing diuretics work. And then before the collecting duct, all of those diuretics were leading into hypokalemia. Okay, and then also, so over here, also working in the collecting duct are the drugs spironolactone and eplerenone. So these drugs are going to prevent aldosterone from binding to the mineralocorticoid receptor, and they're going to, decrease the activity of everything that the increased gene transcription as a result of the mineralocorticoid receptor is doing. So, as a result, you have a decrease in sodium potassium ATPase, you have a decrease in the ENaC channel, and then you have a decrease in the potassium channel down here. So, because of that, so sodium is going to stay in the cell and potassium is going to stay in the body, so again, leading to hyperkalemia. And then up here with the intercalated cells, so the important thing to get from here is the fact that so aldosterone also acts on the intercalated cells, and in the absence of aldosterone, you're going to have a buildup of protons, and they'll eventually be reabsorbed into the body, so that makes the body more acidic. Okay, so we talked about acidosis with potassium-sparing diuretics, and then also hyperkalemia with potassium-sparing diuretics, and that's because it's working in the collecting duct. And then another important thing would be the fact that you don't want to use something like amiloride or triamterene with other potassium-sparing drugs. So these would include things like your ACE inhibitors, your ARBs, and spironolactone. Or if somebody's taking like potassium supplements, for example. Okay. And then spironolactone, that's the big one here, which can cause, again, hyperkalemia and then gynecomastia. And this is due to a decrease in testosterone. So kind of a high yield adverse effect that's often tested on with spironolactone. Okay. So with mannitol, is an osmotic diuretic, and so the way it works is you give mannitol and it's hanging out here in the tubular lumen. So mannitol increases the osmolarity. So as a result, water is going to hang around, and then water is also going to be reabsorbed from the interstitium. So the reason it's known as an osmotic diuretic is it's causing a lot of water loss. And that's due to the fact that mannitol increases the osmolarity. Okay. So here in the collecting duct, we have ADH, which is also known as vasopressin. So ADH is your anti-P hormone. You've probably heard that before. So ADH is going to increase water reabsorption, and then it's going to increase urine osmolarity as a result. So ADH is secreted by the posterior pituitary, and it's in response to increased osmolarity or a decreased blood volume or a decreased blood pressure. So ADH is going to lead to V2 receptor activation, which, so if you look over here, ADH activates the V2 receptors, and this leads to an increase in cyclic AMP, and then your aquaporin channels are going to be inserted in the collecting duct, and that results in a reabsorption of water from the tubular lumen. And then also something that he had in red is the fact that vasopressin and desmopressin, they're used in central diabetes insipidus. Okay, so two of your AVP or arginine vasopressin antagonists are going to be tolvaptan and conivaptan. So basically what's going on here is your AVP antagonists, these two drugs here, are blocking the binding of ADH to the V2 receptor. So water is not reabsorbed because the amount of cyclic AMP is decreased, and you don't get the insertion of the aquaporin channels. Okay, so atrial natriuretic peptide. So its secretion is stimulated by high atrial distension or alpha-1 activation, angiotensin 2, endothelin, and ADH. And when you have ANP released, it's going to increase your GFR, which is going to lead to natriuresis and diuresis. So if you're diuresing someone, you're going to decrease their blood volume, which results in a decrease in blood pressure. And then the drug to know is Nesiratide, which is a BMP analog, and it's going to work basically through vasodilation and also diuresis. And then you should know that Nesiratide can be degraded by neprilysin. All right, so I have a few practice questions. So you're following a hospitalist on your internal medicine rotation, and you watch as she reviews the chart for a 45-year-old male patient with heart failure. She lets you review his lab results, and you determine the patient has a metabolic alkalosis. Which drug will you suggest to correct the metabolic alkalosis? Right, yep, awesome. So the correct answer here, it says acetazolamide. So that's your acid zolamide. So one of its adverse effects is metabolic acidosis. But if you're wanting to turn around a patient with metabolic alkalosis, it would make sense to give acetazolamide in that scenario. And metabolic alkalosis would be common with the patient on like loop diuretic. So you might add acetazolamide to his treatment regimen. Okay, so you recently diagnosed a 65-year-old female patient with primary hypertension and prescribed her lisinopril. On her 3-month follow-up appointment, you discover her blood pressure is still not being adequately controlled. You note that she also has a history of osteoporosis. Which diuretic will treat both her hypertension and osteoporosis? Yeah, you guys got it. So the correct answer here is hydrochlorothiazide. So one of your adverse effects for hydrochlorothiazide is hypercalcemia, which could be, a positive thing in a patient with osteoporosis. And then also kind of something that you learn more next year, I guess, is like the layering of your antihypertensive drugs. So typically, if you start a patient on an ACE inhibitor, if that doesn't control their blood pressure, then the next thing you're going to add is a thiazide diuretic in most cases. It's kind of what the guidelines say. Okay, so use of amiloride is contraindicated with which of the following drugs? And there's actually a couple correct answers here. Right, so A is one. So your ARBs. Spironolactone is one. Yep, it's a potassium-sparing diuretic. And then there's one more. Right, C. So captopril is an ACE inhibitor. So remember, your ACEs and ARMs have an adverse effect of hyperkalemia. Okay, so which side effect is associated with spironolactone? Right, so hyperkalemia. So definitely, something important to keep in mind is which diuretics are producing hyperkalemia in the patient versus hypokalemia. And that's just important due to the cardiac effects and potential drug interactions if the patient is on other antihypertensive meds. Okay. So on to the next lecture. Okay, so he took a minute to kind of review this mechanism here that's happening in the vascular smooth muscle leading to either contraction or relaxation. And I would definitely say, that's what I've seen in practice questions, especially with nitric oxide. They like to see if you know the physiology behind that. So a lot of times when they're testing over the erectile dysfunction meds, just because everybody's familiar with those names, instead of asking you for the drug name, it's very common that they'll ask you for the physiology of nitric oxide. Okay, so if your end result is contraction, you have an increase in intracellular calcium. So calcium is going to bind to calmodulin, and it's going to activate, ideally the arrow should be pointing right here, but calcium and calmodulin are going to activate myosin light chain kinase. And myosin light chain kinase, being a kinase, its job is to phosphorylate. So it's going to phosphorylate myosin light chain and then lead to contraction. So contraction of the vascular smooth muscle, so we're talking about on the vessels, is going to lead to vasoconstriction. And then on the other side of things, if you have a decrease in intracellular calcium, your cyclic AMP is going to inhibit myosin light chain kinase, and cyclic GMP is going to activate myosin light chain phosphatase. So myosin light chain phosphatase is going to rip off the phosphate and lead to relaxation. So relaxation of the vascular smooth muscle is going to lead to vasodilation. And then kind of tying into the next slide, so one of the things that increases or potentiates rather cyclic GMP would be nitric oxide. So if you have an increase in the amount of nitric oxide, you're potentiating the effect of cyclic GMP. So cyclic GMP again is activating myosin light chain phosphatase, ripping out the phosphate, leading to relaxation or vasodilation. Okay. And this is what I was talking about, what they really like to test you on when they talked about the erectile dysfunction drugs is this physiology right here. So in the endothelial cell of the blood vessel lumen, you have nitric oxide synthase, and it's going to convert arginine to citrulline and nitric oxide. So from the endothelial cell, nitric oxide is going to go down into the vascular smooth muscle, and it's going to increase the effects of guanylyl cyclase. So guanylyl cyclase is responsible for converting GTP to cyclic GMP. And then, tying back to that last slide, cyclic GMP activates myosin light chain phosphatase, which rips off the phosphate and leads to relaxation or vasodilation. Let's see. So in the heart, if you're talking about in the heart, because you get the vasodilation, which is predominantly on the venous side, you're going to decrease the preload and decrease the O2 demand of the heart. Okay. So now let's talk about the organic nitrates. So your organic nitrates are going to be nitroglycerin and isosorbide mononitrate. Definitely the one that you're going to be tested over more often is going to be nitroglycerin, and I'm sure everybody's probably heard of that one. So the advantage of using nitroglycerin is the fact that venous dilation is going to predominate, and you're going to decrease the preload to the heart, which decreases the oxygen demand on the heart, so improving the myocardial oxygen supply. So a couple disadvantages that he has in red was the fact that your organic nitrates are going to require breaks, and that's due to tolerance. And then also you can have dependence or withdrawal from them, reflex tach and postural hypertension, and then possible headache. And one of the big ding-dings, I guess, Dr. Quadri's WeBot, that should definitely shows up in a ton of practice questions, is the fact that patients on PDE5 inhibitors should not be given organic nitrates, or vice versa. I mean, really, it would probably be the other way around. If somebody is on organic nitrate, you don't want to give them a PDE5 inhibitor. So if you have someone who, takes nitroglycerin for angina, and then they come in, complaining of erectile dysfunction, you don't want to give them something like sildenafil, because that could lead to kind of like a severe hypotensive episode due to all the vasodilation. Okay. And then your inorganic nitrates are going to be sodium nitroprusside. And one thing you focus on is that your inorganic nitrates are both arterial and venous dilators, and they're not target specific. So with your organic nitrates, they were target specific, meaning that there are enzymes in the target tissues that are going to produce more nitric oxide. Whereas with your inorganic nitrates, they're not target specific and work directly in the bloodstream. So one of the big disadvantages with inorganic nitrates is cyanide and thiocyanate toxicity. So if you have somebody with liver failure, so you cross out the liver, they're more likely to experience cyanide poisoning or toxicity, whereas somebody with kidney failure may experience thiocyanate toxicity because their liver is fine, so the sodium nitroprusside has made it past the liver, but now there's a buildup of thiocyanate because their kidneys can't handle that. Okay, so the two PDE5 inhibitors to know are sildenafil and tadalafil, and they work by preventing the hydrolysis of cyclic GMP to GMP and cyclic, so right here. So they're preventing the breakdown of cyclic GMP, and because of that, cyclic GMP is going to be allowed to potentiate the effects of nitric oxide. Which again leads to relaxation and vasodilation. Okay, and then here again, so super important. You should not use these in patients taking nitrates, and that's due to the synergistic hypotension that can occur. Okay, so with your PDE3 inhibitors, um, which I think the two you said to focus on were milrinone and caffeine actually, so they're going to prevent the hydrolysis of a cyclic AMP to AMP. So if you allow cyclic AMP to stick around, cyclic AMP is going to inhibit myosin light chain kinase. So if you're inhibiting myosin light chain kinase, you're not getting the smooth muscle contraction, and you're getting relaxation instead. All right, so your potassium channel openers. Okay, so your two potassium channel openers you need to focus on would be hydralazine and minoxidil. Minoxidil is kind of unique because this drug is actually used to treat male pattern baldness. And then hydralazine is going to treat hypertension in patients who cannot take ACE inhibitors. But the big thing to know here is the fact that hydralazine has no effect on fetal circulation. So while it may be far from a first line to treat hypertension in most patients, it's actually it has the potential to be a really good choice, for your pregnant female patients who are hypertensive, for example, in eclampsia, and aren't able to take drugs like ACE inhibitors. So if you remember last session, I had a slide. It had like a mnemonic with the antihypertensive drugs that are safe in pregnancy. So that mnemonic is "He loves my neonate." So hydralazine, loves would be labetalol. My would be methyl dopa, and then neonate is going to be nifedipine. So just knowing that mnemonic, I would say definitely next year has the potential to get you a lot of points because it's a super common kind of question scenario to be asked about a pregnant hypertensive, female patient. So you only have so many options as far as drug choices in that case. Okay. So this is a really nice chart that I got out of one of Allie's study guides. And, you guys went over most of this, really almost all of it last exam. So we'll just try to hit the high points and, stuff that I think he's more likely to test you on. So dobutamine. So dobutamine is a beta 1 and beta 2 agonist, preferentially beta 1. So it's going to increase contractility through beta 1 stimulation, and then it's going to vasodilate through beta 2 activation, which is going to decrease afterload and then increase cardiac output, and that's due to the increase in contractility and heart rate. And then also, so albuterol, that's your beta 2 agonist. So if you remember what happens when you activate beta 2, it results in bronchodilation. So albuterol is used to treat your asthmatic patients, which may have, bronchospasms. And, okay. Oh, I put a question in my notes. So what happens if you prescribe a patient who has asthma? What happens if you prescribe them propranolol? So why would propranolol in an asthmatic patient be a bad idea? So think about the mechanism of action. So you're giving a patient albuterol, which is a beta 2 agonist, to treat asthma. Yeah. So propranolol is a non-selective beta blocker. So it can block both beta 1 and beta 2. So yeah, you can actually get bronchoconstriction from the use of propranolol. So something, to consider when you're, prescribing is, to ask your patient, do you have a history of asthma or do you have problems with shortness of breath? And that's, just another reason that using like a beta 1 selective is kind of more, I guess, like preferred because you don't have to worry about that risk. Okay, next is going to be prazosin and doxazosin, which are your alpha-1 antagonists, and then tamsulosin and alfuzosin, which are your alpha-1A antagonists. So these two are used primarily in the treatment of BPH, where prazosin and doxazosin are hypertension, although I think doxazosin can help with BPH too. Don't quote me on that. But anyways, so your alpha-1 antagonists are going to result in vasodilation, and this is due to the blocking of alpha-1. So alpha-1 is your vasoconstrictor. And then the big thing to know here is that so you should avoid using alpha-1 antagonists with your PDE5 inhibitors. And that's, of course, due to all the vasodilation. All right, let's see. So your beta-1 agonists, atenolol and metoprolol. Labetalol, again, is one of those that are safe in pregnancy. So make note of that. Another big one that he kind of emphasized was phenoldiprem. So phenoldiprem is a D1 agonist and is working primarily in the renal arterial beds. So it's a direct renal vasodilator and is used in acute episodes of very severe hypertension. So phenoldiprem in acute resolution of severe hypertensive episodes. So if you have a patient, that comes into the ED that's extremely hypotensive, phenoldiprem would be, an option to get that blood pressure down quickly. Okay. For practice questions, you have a 56-year-old male who presents to the ED with angina after riding bikes with his grandkids. His serum creatinine is 1.7 and his GFR is 50, so basically his renal function is messed up. Which drug is the most appropriate choice to treat his angina? Right, nitroglycerin, and why would you choose C? Why not sodium nitroprusside? Right, that's true, but what about when you see his lab values? His serum creatinine is elevated and his GFR is low. What would he be at risk for if you did? Yeah, methemoglobin. Yeah. So if we go back real quickly to this slide here, yeah, so if his renal function is messed up, he would be at risk for thiocyanate toxicity. Yeah, so the best choice would be nitroglycerin for both those things. So it's specifically venous dilation and also the risk for thiocyanate toxicity. All right, so a 45-year-old male confides in you that his sex life has been unfulfilling due to his inability to maintain an erection. Which of the following statements are true regarding the mechanism of action of the most appropriate drug to treat the patient's condition? Right, yeah. So the correct answer is C. So it allows the cyclic GMP to potentiate the effects of nitric oxide. So the only reason that A is not correct, because you're not getting an increase in GMP because the cyclic GMP is not being broken down. So the cyclic GMP sticks around and potentiates the effects of nitric oxide. Yeah, and I've seen that question several times where they're asking about PDE5 inhibitors, and they want you to know that it's cyclic GMP sticking around that's making things work for that drug. Okay, so a 70-year-old male presents to the ED with a blood pressure of 80/50. The patient's wife states that they're on vacation and she gave her husband one of her nitroglycerin tablets after he developed chest pain during sexual intercourse. You check the patient's chart and notice he has never been to this hospital. What is the mechanism of action of the drug the patient is likely being prescribed that led to his presentation? So what drug was he probably taking? Or what class of drugs? Right, a PDE5 inhibitor like sildenafil. Yeah. So what is the mechanism of action of a PDE5 inhibitor? Right. So it prevents the hydrolysis of cGMP to GMP. Yeah. So I'm kind of harping on that, but I've seen like variations of this question several times, and like I really think it'll be on your exam too. All right. So we'll do the antiarrhythmic drugs. So most of these slides I just pulled directly out of. These questions confuse me because would it be asking this sildenafil or nitroglycerin? So in this case, the wife, so she gave him the nitroglycerin, like yeah, okay, yeah. Yeah, so he wasn't actually being prescribed nitroglycerin, like she just popped him one because he started having chest pain during sex. So what it's asking, it's kind of like the fact that it's like this like stem is the scenario is talking about intercourse, that should kind of tip you off that oh, like he may be taking something to help him get an erection so they can have intercourse. And then also his age too. Okay, so I pulled these antiarrhythmic drug slides. I mainly just pulled them straight out of one of Ali's study guides just because they were so good. Like I didn't see like the ones I made would have made like wouldn't have been as good. So we'll just go ahead and use these. But I did add in some stuff that's from, I don't know if you guys have heard of like the Dirty Medicine YouTube channel, but I added in some stuff, like some screenshots from the video that goes through antiarrhythmics. So if you're like a mnemonic person, maybe some of those will help. Okay, so you have three mechanisms of arrhythmias. So one is increased automaticity, and then you also have triggered activity, which can be early after depolarizations or delayed after depolarizations. and then re-entry either through fixed obstruction or a leading circle like ventricular fibrillation. So your increased automaticity can even sometimes be through normal causes, like exercise or your fight or flight kicking in, leading to sinus tachycardia. And then your early after depolarizations are caused by an inward calcium current leading to or associated with torsades. And then after depolarizations are caused by calcium overload. All right, but the drugs are really what you're going to get the most questions about. Not so much the physiology, at least in this section. Okay, so with Parkinson-White syndrome, basically when you do a 12 lead, you're going to see a delta wave, and this is due to an early conduction through an accessory pathway, which is known as the bundle of Kent. So if you do practice questions, a lot of times they'll ask you they'll show you this, and they'll ask you where the accessory pathway is. So that would be the bundle of Kent. And also in this, you're going to see a wide QRS and a short PR interval, and that's due to that upslope, the presence of that delta wave. Okay. So I'm going to kind of skip to the next slide real quick, and then we'll come back. So this is what I pulled off of that Dirty Medicine YouTube video. So one way for you to remember the sodium channel blockers, if you're into this sort of thing, is think of the salty cab driver, but you would have to put them out of order. So class 1C, class 1A, and class 1B. So class 1C is going to decrease the slope of phase 0 depolarization the most. 1A is going to be somewhere in the middle, and then 1B is going to decrease the slope of phase 0 the least. And then you have, of course, the drugs here associated with each of those classes. In class 1C, so C for can't use post-MI, B for best post-MI, and then 1A, so QDP, so cynicism, and then drug-induced, so prokinamine can lead to drug-induced SLE. Okay, now let's go back. Okay, so that should at least, help you get a few facts from these drugs down. Okay, so 1C, contraindicated post-MI, 1B is best post-MI, and then 1A, the QDP is associated, or that mnemonic was associated with the fact that class 1A can lead to torsade de pointes. But also two important things to point out here are the fact that your class 1A drugs increase the QT interval. So if you block sodium channels, if you block your fast sodium channels in phase 0, it's going to take longer for the ventricular myocyte to depolarize, and that's going to result in a widened QRS. Whereas if you block potassium channels in phase 3, your QT is going to be prolonged because it takes longer for repolarization to occur. So that's where you get this prolonged QT interval from. It's from the blocking of potassium channels in phase 3. So if you're wondering, okay, class 1A and class 1B, they're both sodium channel blockers. Why does one prolong the QT interval and why does one decrease it. So it has nothing to do with the sodium channel. It's actually the fact that class 1A blocks potassium channels in phase 3. So that gives you the longer QT interval because you're taking longer for repolarization to occur. Let's see. I would say the other important thing from here would be the fact that flecainamide would be your last resort due to its pro-arrhythmic effects. And that's because you get a strong depression of phase 0. So 1C decreases the slope of phase 0 depolarization the most. So that's going to be your last resort, and that's because of the pro-arrhythmic effects. Okay. So next we have the class 2 drugs. So these are your beta blockers like propranolol and esmolol, and these are going to slow down phase 4 in the SA and AV nodes. So make sure you realize that with our sodium channel blockers, we were referring to the ventricular myocytes, whereas in phase 2, we're talking about our pacemaker cells. So with our class 2 drugs, we're depressing the SA node automaticity and slowing the conduction through the AV node. So by slowing the conduction through the AV node, you're going to see an increase in the PR interval. So I would definitely know that. And then also the fact that your class 2 drugs are first line in treatment for atrial fibrillation. Okay. And that's due to the fact that you're slowing down the conduction through the AV node. Okay, so here's a clip from that Dirty Medicine video. So with our beta blockers, we're thinking 4 letters. So 4 letters with beta, 4 letters with SA and AV nodes, so slowing the conduction through the AV node. OLOL, so our drugs ending in OLOL are beta blockers, and then AFib. So first line for AFib, all of these are 4 letters. Okay. Let's see. Okay, so your class 3 drugs are your potassium channel blockers. So potassium channel blockers are going to slow phase 3 in the cardiac myocytes. There we go. And let's see. So all of your class 3 drugs are going to prolong the QT interval. And so anytime you see a prolonged QT interval, this is going to increase your risk for torsades. So that's with class 1A and class 3, with the exception of amiodarone. But if you do have a patient with torsades, you're going to treat them with magnesium. So magnesium is going to block calcium influx and correct the hypokalemia. And then, so a couple important adverse effects that tend to show up in questions would be the fact that amiodarone can lead to hyper or hypothyroidism. Also, you can see the Smurf skin. So if a patient looks real blue, they ask you what drug they're taking or that they've taken. It could be amiodarone. And this is very important here, that the fact that amiodarone, so your class 1A and class 3 antiarrhythmics, prolong the QT and lead to a risk of torsades with the exception of amiodarone. So I would kind of expect that to show up on the test somewhere because that's a very important point. Okay. Yep, and then the other two, a risk of torsades. Then, of course, you need to know that all three of these drugs are blocking the potassium channels in phase 3. Okay, so the trick for this one, so it was the 3. So it's working, so your class 3 drugs are working in phase 3, and then so TDP referring to Torsades, so 3 letters, and then with these drugs, I don't think you really talked about it, but you need to check pulmonary function tests due to some adverse effects, and then liver and thyroid function tests. So remember hyper and hypothyroidism, and then the fact that it inhibits CYP450. This one might not be as helpful, sorry. Okay. Your class 4 drugs. Okay, so verapamil and diltiazem, so they both block the calcium channels. They slow or block phase 0 and phase 4 in the SA and AV nodes. They increase the PR interval. And then also they are contraindicated in use with beta blockers. So if you are decreasing the heart's contractility by giving a calcium channel blocker, and then you're also using a beta blocker to slow down the heart rate, so that leads to like a synergistic effect, and that's why beta blockers are contraindicated in use with your calcium channel blockers, because they're having the same effect and it could be too much. Okay, so the trick they had to remember your calcium channel blockers is, so 0 plus 3 plus 4 equals 7, and there are 7 letters in calcium, so your calcium channel blockers are decreasing the slope of phase 0, 3, and 4. Okay. So, next we have digoxin. So dig is used like first line in patients who have AFib and heart failure. The thing that's probably going to show up on the test though is some of this toxicity. So digoxin can lead to green-yellow vision, so you might see yellow halos around lights, and then hypokalemia can lead to dig toxicity. So if your patient's being given dig with one of these drugs that can cause hypokalemia, you can get dig toxicity. And then if you have someone who presents with a dig toxicity, you're going to treat them with Digibind. Okay, so adenosine, all you need to know here is the fact that it's going to slow down phase 4 by opening potassium channels, and it's used in the treatment of SVT. So, it might be a good idea to kind of look at some rhythm strips and make sure you know that what SVT looks like, because like they could show you the strip in a question and then ask you what you're going to treat the patient with. So that would be adenosine. So adenosine is the Control-Alt-Delete for the heart that does stop it for a second, and then it resets the rhythm. Okay. And then Allie made this really awesome summary. So, again, just realize that your class 2 and class 4 drugs are working on your pacemaker cells, and then your class 1 and your class 3 drugs are working on the cardiac myocytes. And then, it's really important to know exactly where they are working, like where within the action potential, like what phase they're blocking or decreasing. Okay, so question here. So you're rotating in the ED and an ER tech hands you the 12-lead ECG at the right. The patient you're about to see is being treated for atrial fibrillation. You suspect the patient is taking which drug? So, do you guys recognize what this strip is showing? Like, I know you guys see, we had somebody different for CardioPhys last year. It was a guy that came from like Pikeville, the DO school in Pikeville. So, have you guys like been shown this pattern before, like that scribbly wavy? I think he had an example. Dr. Quadri had an example of this in his lecture, like this, that really wavy, looking crazy line. Familiar? So this is torsades. So this is what torsades looks like on a strip. It just looks like a crazy, like wavy line, basically. So if the patient shows up with torsades, which of these drugs do you think they might have been taking? So which of these drugs puts the patient at risk for torsades? Yeah, good job, Leah. So procainamide. An adverse effect of procainamide would be torsades. So make sure you know which drugs come with the risk of torsades. And then be able to recognize it. So just crazy squiggly line, torsades. Okay. So you've determined that the patient was taking procainamide and he has torsades. So how are you going to treat him? Right, great. So magnesium to treat torsades. So, both of these questions are pretty high yield, like knowing which drugs carry a risk of torsades and then knowing how you're going to treat the patient. Okay, so kind of a first order question. So which class 1 antiarrhythmic is contraindicated post-MI? Right, so flecainide. That's correct. So flecainide, I believe, is class C, right? Yeah, so class 1C. So it's contraindicated post-MI, and then class 1B, so that Dirty Medicine video, so 1B, so B is the best post-MI. Okay, so you have a 5-year-old female brought to the ED with sinus arrest and ventricular rate of 35 beats per minute. A bottle of her uncle's digoxin was found where she was playing. Which drug will treat a severe overdose of digoxin? I promise it isn't. This isn't a trick. Right, yeah. So digoxin antibodies, so Digibind, is actually digoxin antibodies. So that's going to treat digoxin toxicity. Okay, so kind of like with the last exam, or just like with pharm in general, anytime you talk about like toxicity or overdose, it's very high yield to always know what you're going to do to treat that. All right, that's all I got for you guys tonight. You're welcome. I hope everything's going okay, and we've only got like, what, a couple more weeks? Yeah, you're so close. I know I was like almost in tears walking out from the cumulative after first year just because I was like so excited to be done. Yeah, I totally understand. Well, just gotta keep pushing. All right, well, I hope you guys have a good rest of your night. And, like, as always, feel free to message me if you need anything at all. Yeah, I really, like, as much as you can, like, I really enjoyed NeuroInform. Yeah, it starts to get, like, a lot more clinical, and I think you feel like it feels more like you're in medical school, I guess, or it did to me. All right, well, I'm gonna get off here. You guys have a good night.